Hey guys, and welcome back to the How to Ace Your Unseen Case video series. This is episode number 4. It's actually going to be airing before episode number 3 because I've had a little bit of issues with editing, re-recording of episode number 3. So episode number 4 is going to air first, and episode number 3 is going to air in position of episode number 4. So yeah, basically this is a video series, if you haven't seen the video before, where I take you from start to finish of everything you need to know in a nutshell on how to ace your unseen case at dental school. So it's particularly aimed at kind of 4th and 5th years, but I think there's a lot of value that anybody at dental school can get out of this, because I go through the basics in detail and all of the guidelines and things that you need to know. And then at the end of the presentation, we finish with a case example that we discuss through together. So today we're going to be going through oral surgery. Now, oral surgery for me at university was my favourite subject. I loved learning about it. I loved the oral surgery clinics at Barts. We had really nice oral surgery clinics that ran once or so a week. And even in foundation year, I still really enjoy taking teeth out, the challenges, managing patients with potential complications, the kind of things that we're going to discuss today. So it's something, that I enjoyed learning about, still enjoy learning about. I'm going to enjoy teaching it in this video as well. So you can see, just quickly before we begin, I've got my shameless plugs on the bottom left hand screen, bottom left hand of the screen. So if you can follow me on Instagram and TikTok, that would be a really helpful thing to do to help me grow and give me the motivation to basically keep producing the content that I love to produce. So you can find me on those platforms at Tiller Talks Teeth, and of course please subscribe to the YouTube channel as well. So before we begin, I basically just want to point you in the direction of the SDSEP, which is the Scottish Dental Clinical Effectiveness Programme. And essentially what they are is they're a body that produce lots of guidelines that we as dentists use day in, day out. So a lot of the content that I'm going to be referring to today, I've taken directly from the SDSEP guidelines. Examiners love to use that content, and examiners love to know that you have an understanding of how to manage a patient based on the guidelines that they give. And what's great about SDSEP is they've actually produced 2 apps that are really helpful to use. One is about antimicrobial prescribing, and the other is basically all of the PDF guidelines that they've got. So things like bleeding, things like MRONJ, and things like antimicrobial stewardship. So I'd recommend downloading those. I have those downloaded onto my tablet that I use in practice all the time if I need to refer to something quickly. It's a really good tool to have basically alongside your revision notes to refer to. So without further ado, let's get our teeth stuck into one of the main topics in oral surgery, which is bleeding. And this is essentially identifying patients that are at high risk of bleeding and managing them accordingly. So as you can see on the screen, this is the front cover of one of the guidelines that SDSEP produce that we as dentists are expected to follow when we're managing patients in this category. So before we sink our teeth into the actual things that cause bleeding and how we manage bleeding, we need to have a good understanding of hemostasis within the body. So you can see on the screen at the moment there's quite a complex kind of flow, and it's something that I hated learning about at university. There's a lot of Roman numerals, a lot of big words, and it just took me a long time to get an understanding of it. So this is actually a screenshot from the Osmosis YouTube channel, which I will link in now. And it's basically a really good video explaining the coagulation pathway in the body, probably a lot better than I can do it, with really nice visuals. So I would check that out and probably watch that video before we continue and have a good understanding of how the pathways work. Because essentially what it is it's a way that hemostasis is activated within the body. So if you're to cut yourself, you have 2 types of hemostasis. You've got your primary hemostasis, which happens straight away, and essentially this is an acute management of the bleed. So you have vasoconstriction of the blood vessels in the area to reduce the blood flow there, and then platelets will try and plug it. However, this isn't so stable, so the body, once it's initially been stopped, will want to form a nice stable fibrin clot. And this is where your coagulation pathway comes into play. Lots of things are activated by various different factors via the intrinsic and extrinsic pathways to form a nice stable blood clot at the end. So yeah, have a real good understanding of this, and then let's crack on with the actual video itself and the bleeding. So before we start talking about bleeding management and how to actually manage a patient who's bleeding, we need to understand the medical conditions and medications that can actually put a patient at a higher risk of bleeding. Typically, a lot of them are going to be more elderly patients, and quite often they have complex medical histories or polypharmacy. So a patient might come to you that needs an extraction and they might not actually remember all of their medications and medical history. They might forget their prescription list, and you need to be aware as a clinician of the conditions and medications that can cause this. So you need to be able to look through their previous medical history and perhaps pick something out. Or if you're thinking about doing an extraction, you need to be able to ask questions where you can ascertain the risk of the patient. For example, are you taking these anticoagulants? Are you taking any antiplatelets? Or do you have one of these conditions? So this is a screenshot from the SDSEP guidelines, and it's basically just the table that outlines common medical conditions that are associated with an increased risk of bleeding. So it's good to know these common conditions, and we'll run through them quickly now. So the first couple are in relation to organ failure, and we've got chronic renal or kidney failure, and also liver disease. And these are both relevant because they produce factors that help a blood clot form. So in chronic renal failure, you can have platelet dysfunction and less likely for a platelet to form. And in liver disease, you can have reduced coagulation factor production, because the liver is actually the site at which you produce all of your coagulation factors in your coagulation pathway. So if you have liver disease or poor liver function, some or all of the production can be disrupted. And I had a patient the other day who came in who chronically drank 100 units of alcohol per week, and he was due to have an extraction. And obviously, as a clinician, I was quite concerned. I was thinking, well, does this patient have optimal bleeding? So what I did was I actually sent the patient for blood tests at the GP to do a full blood count, and then an assay of the clotting factors, amongst various other things, just to make sure that I felt comfortable extracting the patient's tooth in general practice, and I understood if I did or didn't need to have a protocol in place to manage him if he was at high risk of bleeding. Other common ones are things like if a patient's taking chemotherapy. This is a lot more common, and it will become more common as more patients are living longer and cancer's becoming more common. So chemotherapy essentially causes something called pancytopenia, and pancytopenia essentially means low levels of all types of blood cells. Other things that we'll talk about in more detail later are your inherited bleeding disorders, so von Willebrand's disease, haemophilia, etc. And there's something also called idiopathic thrombocytopenic purpura, which essentially is an idiopathic, so no cause, but you have a reduced number of platelets. And then we basically have medications that can affect bleeding as well. And we're going to go into a lot of detail about your anticoagulants and antiplatelets later, but there are a few others that can affect bleeding and put a patient at an increased risk of bleeding. And one of the ones I think we really need to be aware of that we're going to see in day-to-day dentistry are painkillers. So things like NSAIDs, so ibuprofen and aspirin, they do put the patient at an increased risk of bleeding purely because the mechanism of action inhibits platelet function. So these are things that we need to be aware of. If we have a patient at a high risk of bleeding, we're going to do an extraction, then perhaps we're not going to offer these as pain relief, and we're going to have an alternative like paracetamol. Next, we need to look at the bleeding risk of a patient, because how you manage a patient with a low risk of bleeding procedure and how you manage a patient with a high risk of bleeding procedure based on the SDSEP guidelines will differ. So again, another table taken from the SDSEP guidance, and I think the most important one to understand is what's the difference between a high risk of bleeding and a low risk of bleeding extraction. So SDSEP think that, or suggest that, simple extractions are a low risk of bleeding procedure. So a simple extraction could be something like a periodontally involved tooth where there's, grade 1, 2, 3 mobility, lots of bone loss, and the tooth will come out quite atraumatically. They also consider things like single-rooted teeth, anterior teeth, anything that's not going to leave a large socket behind. These are all things they think are a low risk of bleeding procedure. In terms of a high risk of bleeding, we're basically talking about complex extractions, so the opposite. So things that may be traumatic, so maxillary molars, mandibular molars, things with multiple roots, things that are going to leave a large socket, things that you might have to raise a flap for, because that's definitely going to cause the patient to bleed. Essentially, it's just about using common sense. If you have a maxillary molar, but it is grade 3 mobile, it's unlikely to cause a lot of bleeding. So have a good understanding about this in the back of your head, because every time you do have a patient at risk of bleeding, you're going to need to refer to this and make a judgment call based on that. And now that we understand what causes bleeding, what the risk of bleeding is with the procedure, we then need to basically understand, well, how are we going to manage this bleeding? And we can split this into two sections, two things that you're likely going to be asked during an exam. And these are, how do you manage a patient that's at a higher risk of bleeding? And these are the things that you do pre-op. And how do you manage a patient that presents to you in practice with post-op bleeding? There's a little bit of overlap between the two, but obviously one is preparing and one is being reactive. So if we start with patients that are at a high risk of bleeding, for example, if you have a patient who attends who needs an upper 6 taken out, and you've identified that this is a high risk of bleeding procedure, and you've identified that the patient has a medical history factor that puts them at risk of bleeding, what are you going to do prior to that treatment? And there's a lot of things you can do, and a lot of them are quite straightforward. So the first things you can do are you can prepare. So these are things like having early morning appointments or appointments early during the week, because these patients are more likely to come back with bleeding condition, with post-op bleeding, and immediately after the extraction, it might take them a little bit longer to obtain hemostasis. So if you've got a patient with a difficult extraction, you're not going to book them in on a Friday afternoon when you can't manage it. When the clock hits 5, you want to get off. So it's good to get these patients in, early morning and early during the week, so that if something does happen, you can manage it appropriately. Something you can do before, like I spoke about earlier, is you can check the recent bloods. If you're concerned about clotting or bleeding, you can liaise with the GP and ask for recent blood results, or you can refer the patient to their GP to have blood results. It's very simple, very straightforward, and it'll give you a little bit of extra information and peace of mind as well. When it comes to the actual extraction, there are things you can do as well. You can consider, for example, if you have multiple extractions, you consider doing them over multiple appointments, or consider staging the area which you do them. For example, if a patient needs all 6s out, you're unlikely to take all 6s out at that one appointment. Perhaps you can do left-sided 6s at one appointment and right-sided 6s at the next appointment. If you have a patient that you know is at a higher risk of bleeding, you're already going to be thinking about the things you can do, during the extraction, and packing the socket with Surgicel and suturing is a great thing you can do to encourage hemostasis and reduce the primary bleed at that site. Tranexamic acid wash, it's something that SDSEP mentions, but something that as dental clinicians that we may not really use too often. So what it is basically is it's a drug that binds to plasminogen, and it essentially prevents a fibrin clot being broken down. So you're more likely to have a stable fibrin clot form. The wash is typically used post-extraction, but us as dentists, we aren't actually able to prescribe it. It's not in the dental prescription formulary. So if it's something that we do want to use, we have to go via the GP or the patient's hematologist or cardiologist to get that. But it's something to be aware of as well. And then we get to the things that you can kind of do post-extraction to minimize the risk of a patient bleeding. So these include thorough post-op instructions. So things like not rinsing, not soiling, biting on a gauze for 10 minutes, and also safety netting. So you can tell a patient that blood in the saliva for a couple of days or blood in the toothpaste is completely common after an extraction, but the socket shouldn't ooze or drip. And if the socket does ooze or drip, you can provide them with a gauze that they can bite down on for 20 minutes. And if it doesn't stop, then they should seek an emergency dental service or come back to the practice for an appointment to try and manage that. And that leads us quite nicely on to the next point, which is how we're going to manage a patient who turns up in our waiting room, with blood all over the face, dripping from a socket of an extraction that you've taken out recently. So there's a few things that we need to bear in mind before. The first thing is we need to kind of have a brief understanding of the types of bleeding that you can have post-op. So these are split into 3 sections. You've got your primary bleed, which is something that's all the blood you see during an extraction. You have a reactionary bleed, and this essentially is where a blood clot doesn't form in the couple of days post-extraction. Or you can have a patient that actually turns up about 7 to 10 days after you've extracted a tooth with a bleed. And essentially what's happened is there's been an infection in the area that's caused inflammation and a bleed in the area as well. So in terms of managing it, the first thing you can do, which I actually haven't written down, but I just thought of, is you need to calm the patient down. To them, blood, they might have blood on the lips, blood dripping from a socket can be quite, can cause a lot of anxiety. So it's sensible to, take them into a quiet room, clean them up and get them to bite down on the gauze and just try and stop it immediately. Whilst you're doing this, it's a good idea to recheck the medical history. Just see if there's anything that you've missed out of that might put the patient at a high risk of bleeds. And then have a good old look in the socket under good lighting. You want to understand kind of the source of a bleed and how to manage it. So is the bleed from bone or is the bleed from soft tissue? Is the bleed even from the socket itself? So yeah, have a good look under a good source of light. Once you've identified it, then you can basically do the things that we spoke about earlier to prevent the bleed. So get the patient to bite down on a gauze, and don't just stick the gauze in the mouth and say bite down on this. Really wedge the gauze into the socket and ask them to bite with a considerable amount of pressure on that gauze. You can give a local anaesthetic. There's adrenaline in LA that will cause vasoconstriction in the area, so kind of reduce the risk of bleeding in that area. And then again, you have your other things like pack with Surgicel, suture for primary closure, and you can again consider a tranexamic acid wash. All right, so let's talk about coagulation disorders and coagulation medication. So I've pulled these up basically from the table that we spoke about a few slides ago, and I'll just quickly run through what they are because they are common conditions that we need to be made aware of. And they're basically all anticoagulation disorders that can put a patient at a bigger risk of bleeding. So the first one is von Willebrand's disease. And essentially what this is it's a condition where you produce less or no von Willebrand factor. And von Willebrand factor is a protein that binds to factor VIII and prevents it from being degraded. So if you have less von Willebrand factor, you essentially have less factor VIII in your intrinsic pathway and you're less likely to clot. Von Willebrand factor also plays a role in platelet plug formation, so it can be considered as a dual antiplatelet, dual anticoagulation disorder. Haemophilia A and haemophilia B are sex-linked disorders, so essentially you'll see them with a male prevalence. And again, they both affect the intrinsic pathway, but in slightly different ways. Haemophilia A affects factor VIII, very similar to von Willebrand's disease, whereas haemophilia B affects factor IX. And again, down the line, they'll produce less clotting. Vitamin K deficiency is an interesting one, and it links quite nicely to warfarin. Vitamin K is something that is used to produce 4 clotting factors in the liver, so factors 2, factor 7, factor 9, and factor 10. And the way that I used to remember it is 2 plus 7 is 9, and add on 1 is 10. I don't know if that makes it any easier, but for some reason it's one of those things that's just stuck in my head forever. So yeah, another important one to know. And finally, liver disease, again, something we spoke about earlier. All coagulation factors are produced within the liver. So if you have liver dysfunction, you're a lot more likely to have lower production of clotting factors. And now moving on to our anticoagulant medication. Warfarin is massive, and it's something you're most likely going to get asked on at some point during dental school. It's becoming less common because you've got your novel anticoagulants that are coming out, but you'll still see so many patients that take warfarin, so it's something that we need to know inside and out, basically. And what warfarin is, it's a vitamin K dependent antagonist. So it inhibits the production of those 4 clotting factors that we spoke about previously. So factor 2, factor 7, factor 9 and factor 10. And it affects both the intrinsic, extrinsic and common pathways. So it does have quite big anticoagulant potential. A patient would be taking warfarin for a number of reasons. It could be used to prevent stroke, or in a patient that's had a stroke or a TIA. It could be used in the prevention of deep vein thrombosis or pulmonary embolism, blood clots. And it can be used in some patients that have coronary heart disease and patients that have prosthetic valves as well. The management is quite unique, and it's really important to understand as well. And the big key word that you need to know is the INR. And the INR basically stands for International Normalized Ratio, and it measures the prothrombin time of a patient. And the prothrombin time essentially is a measure of the extrinsic pathway and a measure of how quickly a patient clots versus the gold standard. So if I was to cut myself, for example, my INR, because I don't have an anticoagulation disorder, would likely be around 1, which means I clot at a normal rate. However, a patient that's taking warfarin, if their INR is 3, essentially it means that they are going to clot 3 times more slowly than I will. And it's as simple as that. And the reason that INR is important is because there is a guideline of when you can and can't extract a tooth from a patient. So you can see there's a little yellow book on the right hand side of the screen, and a lot of patients will carry this with them when they take warfarin. And what it is it's just measures it's a record of the measurements of INR. They'll be having their INR measured routinely at the GP, and what you want to be looking for is the INR greater than 4 or is the INR less than 4? If the INR is greater than 4, then we're not doing that extraction. We need to liaise with the GP and we need to try and bring that INR below the level of 4, because it means they're at a super high risk of bleeding post-op. If the INR is less than 4, then that's our safe zone, that's our safe number. And it essentially means that we can treat the patient without interruption, do the extraction, but we need to have our bleeding management protocol from a few slides ago. We need to have that ready to go, and we need to be deploying those things. What's important about the INR as an exam answer is that it needs to be measured within a certain amount of time prior to the extraction. So the gold standard is within 24 hours. So say you have an extraction at 12 o'clock on a Tuesday, you would want to do it from 12 o'clock on the Monday. But if we're unable to do that, then up to 72 hours is accepted as well. And yeah, you also need to be aware that warfarin has a lot of interactions with other drugs. So if you want to have a really good exam answer, something that I would say when I'm managing warfarin, I would talk about the INR, 24 hours, 72 hours, less than 4. And then I would also say that I would refer to the BNF for warfarin's drug interactions, because warfarin is metabolized by cytochrome P450 in the liver, and cytochrome P450 interacts with a lot of other medications as well. And these medications can either potentiate the effect of warfarin, so increase the anticoagulation effect, for example, like the drugs on the left of this table, or some drugs can kind of inhibit or antagonize the effects of warfarin, so they can actually reduce the anticoagulation effects, like the drugs on the right. And there's a huge list on the BNF, so make sure you're always saying that in your exam. Say, I would check the BNF for any drug interactions with warfarin. So NOACs are other anticoagulants, and they are basically novel oral anticoagulants, and they're the kind of medications that are slowly replacing warfarin. So we're going to see them more and more frequently throughout our careers, and it's good to stay on top of the NOACs that are out there and the NOACs that are being produced. So NOACs, similarly to warfarin, are used in cases like prophylaxis against stroke and prevention of DVTs and PEs. There are lots of kind of NOACs out there, but the common ones are rivaroxaban, edoxaban, apixaban, and dabigatran. and they affect different factors. So the way I like to remember it is rivaroxaban, edoxaban, and apixaban all have XA in there. So XA, I don't know why I said that. All have XA in the name, and that basically is a good clue that the thing they inhibit is factor 10A, XA. So it's a really good way to remember that. Dabigatran, on the other hand, doesn't have an XA in the name because it doesn't inhibit factor 10. It actually inhibits thrombin. And the good thing about NOACs is that they've got quite short half-lives. Therefore, you can manipulate how they are taken around an extraction when you're extracting a tooth from a patient. And the management is, again, specific to the NOACs itself. And something key to note is that according to SDCEP guidelines, the management of a NOAC is only relatable to a high risk of bleeding patient. So in a low risk of bleeding procedure, you wouldn't stop a NOAC or adjust the dose of a NOAC or when it's taken. You would just use your general bleeding management strategy. However, in a high risk of bleeding extraction, it's acceptable to stop or miss doses. So you can see on the screen that each drug is dependent on when it's taken and how often it's taken throughout the day. So rivaroxaban and edoxaban are once daily taken medications, and typically they're taken in the morning. So if you have a patient who is having an extraction around lunchtime, you would say to the patient, well, please miss your morning dose of rivaroxaban, but please take the dose 4 hours post-op. Apixaban and dabigatran are slightly different. These are taken twice a day. So advice for these patients is you would miss your morning dose and you would take your evening dose as normal. You would, again, like I said, use your high risk of bleeding management and go from there. So antiplatelets are another class of medications that can put a patient at high risk of bleeding, but work slightly differently to anticoagulants. When you're talking about platelets, it's good to understand the values of what is normal and the values of what is typically safe to do an extraction. Because this can be relevant when you're looking at bloods and you're looking at the platelet level. You need to know kind of, can I extract, can't I extract? So in a normal patient, an everyday patient, it's normal to have 150,000 to 450,000 platelets per microliter of blood. And that's someone who should clot nicely. For an extraction, you need to be aware that it is acceptable to do an extraction anywhere as low as around 30 to 50,000 platelets per microliter of blood. Anything less, and then you need to manage it slightly differently or delay the extraction itself. So antiplatelet guidelines in SDSEP for management are very straightforward, and you can see a little flow on the screen now. So if you're taking aspirin, which is a really common antiplatelet, then you treat without interruption. You do the extraction. But again, like everything else, you discuss your general bleeding management protocol. It differs not really much, but slightly if you're taking aspirin with another antiplatelet, so a dual therapy. And again, you treat the patient without interruption. You do the extraction. You do your general bleeding management protocol, but the only real difference is that you need to be aware that the patient might bleed for a little bit longer. So in a patient that's taking aspirin versus dual therapy, for the dual therapy, you might book an extra 10 to 15 minutes to manage the hemostasis accordingly. But as a general rule of thumb, any antiplatelets with a platelet level above 30 to 50,000, you treat without interruption and use your general bleeding management protocol. And just as a final kind of word or thing to be made aware of, not strictly related to bleeding, but related to the cardiovascular system, is what do you do for a patient who's had a recent CVA, so heart attack, stroke, something like this. And the guidelines seem to be changing, and I remember answering a question, and I remember referring to these, and I think it went down quite well. So the SDSEP, what they currently recommend is that a patient who's had a recent CVA, you delay all non-emergency dental treatment for 6 months. So these are your routine things like scaling, fillings, endo, things like that. However, there's now emerging evidence that's coming out, and I will link it somewhere on the screen, There's emerging evidence coming out that you can have a 4 to 6 week period of caution now following a CVA. And this basically means that emergency dental care can be done, but it has to be done in a secondary setting. After this 6 weeks, then, unless a patient's cardiologist advises otherwise, you can do all routine dental treatment. So that's our bleeding done. And that brings us on to another huge topic in oral surgery, which is MRONJ. And, oh, there's my dog. You can see, again, MRONJ have, stop your tail, MRONJ has really big guidelines from SDCEP, and it's something that you need to know inside and out. MRONJ is something you're very likely going to get asked in an exam, so it's good to have a real good understanding of the guidelines. So MRONJ stands for Medication-related Osteonecrosis of the Jaw, and it's replaced the historical term BRONJ, which was bisphosphonate-related osteonecrosis of the jaw, because it's not just bisphosphonates that can cause osteonecrosis of the jaw now. As a key definition, it basically is bone that is exposed or bone that is probable through a fistula in the oromaxillofacial that's persisted for greater than 8 weeks post-extraction. 8 weeks is used because in a typical extraction site, 8 weeks is sufficient time for the bone and soft tissue to heal. If you were to review a patient in fewer than 8 weeks, you could confuse MRONJ for another pathology like dry socket. In a patient with MRONJ to be classified, you also have to have a history of treatment with anti-resorptive or anti-angiogenic medications. And you have to have had no history of radiotherapy to the head and neck region, because radiotherapy to the head and neck region can cause a similarly presenting condition called osteoradionicrosis of the jaw. Medications that cause MRONJ are typically used for kind of bone stability and to reduce bone turnover. So common conditions they use for are things like osteoporosis, fibrous dysplasia, hypercalcemia, and Paget's disease of the bone. They're also used in the treatment of malignancy that can have bony metastasis. So common ones are breast cancer, prostate cancer, and lung cancer, amongst others. And they can be used in the treatment of malignancy that doesn't have bony metastasis, with a key one being multiple myeloma. The incidence, according to SDSEP, whilst there's evidence to suggest the incidences might be changing, figures that you need to be able to quote are if a patient is being treated for a non-malignant disease, it's about 0.1 to 0.01%, so 1 in 1,000 to 1 in 10,000 people. And if a patient is being treated for a malignant disease, then it's about 1% or 1 in 100 incidents. So anti-resorptive medication that you typically get, these are commonly they're not commonly. These are bisphosphonates, basically. That's the classification of the drug. And they end in nate, typically. So you have common ones, which are alendronate, zolendronate, and risodronate. Sometimes they end in acid. So instead of alendronate, it would be alendronic acid or zolendronic acid as well. So those terms are interchangeable. And essentially what this class of medication does is it induces osteoclast death. So it reduces the turnover of bone itself. And one key thing to note about bisphosphonates is that they have a really long half-life of about 10 to 15 years. So once they've bound to the bone, they're going to be there for absolutely ages. So when you are classifying risk, which we'll talk about in the next couple of slides, with a patient who's on bisphosphonates, you basically need to be aware that anyone who's taken bisphosphonates, even if they've stopped for 5 years, you need to treat them as if they're still taking that. So that's something key to know about bisphosphonates. Another class of medication are your RANKL inhibitors. So a common one that you'll be made aware of is denosumab, and it's a monoclonal antibody, and it basically prevents osteoclasts from maturing. So instead of like bisphosphonates causing them to die, they just don't become mature and functional. Finally, you've got, actually no, let's jump back. With respect to denosumab and that's half-life, it's a lot shorter than bisphosphonates. So if you were to do a bone profile of a patient taking denosumab, once they've had it, 6 to 9 months later, it would be back to normal. So if a patient's had historically had denosumab, then you don't need to treat them as if they're still taking it, unlike in bisphosphonates. Finally, you need to be made aware of anti-angiogenic drugs. So these are used in malignancy and prevent tumours from kind of vascularizing and having a blood flow. And common ones are bevacizumab and sunitinib. So you need to be made aware of those as well. So it's really important to understand, similarly to bleeding, the risk for MRONJ, because your management of a patient at risk will be dependent on if they're low risk or if they're high risk. So I've taken a table directly out of the SDSEP guidelines, and this is something that you need to know for exams. If you're categorizing risk, this is the guideline that you refer to, irrespective of other things that you might have seen. And the way the SDSEP do it is they basically classify risk based on duration and based on why you're being treated. SDSEP don't really take into consideration the modality. They classify it as a patient who has it oral or intravenous as having the same risk. So if you're asked in an exam, does IV increase the risk? Then your answer would be to say, according to SDSEP guidelines, modality of treatment doesn't affect the risk. It's based on duration or why it's being taken. But have a good understanding that there is a lot of emerging evidence. So you can even say this, you can say, but there is emerging evidence that a patient who is having IV bisphosphonates or IV treatment is at a higher risk of MRONJ than someone who is having it orally. But in terms of your exam answer, your gold standard exam answer, a patient who is at low risk is someone who has been taking bisphosphonates for less than 5 years, or is currently taking denosumab and is not taking any concurrent corticosteroids. Or it's a patient who is or it's someone who is being treated for non-malignant disease, so something like osteoporosis or fibrous dysplasia, something like that. A patient who is at a high risk of MRONJ formation is someone who is taking bisphosphonates for greater than 5 years, or it's someone who has been taking bisphosphonates for less than 5 years or is currently taking denosumab with a concurrent corticosteroid. And corticosteroids are quite important because they're immunosuppressant, so the patient is less likely to heal as well. And corticosteroids actually modulate bone metabolism, so they increase the amount of osteoclasts that are secreted. So if you see someone who is at risk of MRONJ, always double check for if they're taking corticosteroids. And this is typically oral or IV. You don't really consider someone who's taking topical corticosteroids for a skin condition. Other things that could put you at risk of higher risk of MRONJ is if you're being treated for malignancy. So even if you've had a bisphosphonate for a year, if it's being taken for a cancer, automatically that person is high risk. So it's irrespective of the duration. And a patient is considered at higher risk if they've previously had MRONJ in the past. Other factors that we need to be made aware of but don't affect the SDSEP risk guidelines are you're at higher risk of MRONJ if you have a mandibular extraction versus a maxillary, if you have a posterior versus an anterior extraction, so third molars as well, if you have a patient who is immunosuppressed or immunocompromised, patient with poor oral hygiene, if you have a traumatic extraction that will affect bone turnover more, and if you have ill-fitting dentures, because these can put unnecessary force and pressure on the mucosa as well. So have a real good understanding of that, and then we'll discuss how you manage the patient accordingly now. And there's a lot of factors to consider when you're managing a patient who is on or is going to start on bisphosphonates. So I've had quite a few patients who have come to me this year before they've been starting one of these medications, because there's things that you can do prior to them starting to minimize the risk of them needing an extraction. So they'll come in and they'll say, I've been referred by my doctor for a dental exam because I'm on this medication. And more often than not, they may not understand why. So the first thing that you're going to be doing is you're going to explain the risk that taking this medication has on their oral health. Once you've done this, you need to ensure that the patient is dentally fit. So you want to be doing all of your preventative work, your restorative work, and you want to be extracting teeth that have a hopeless prognosis. Basically doing everything in your power to reduce the risk of that patient needing an extraction whilst they're taking this medication. And this will include a really good preventative plan as well. So what I typically do for my patients is we go through oral hygiene instruction, we go through diet advice. I'll typically prescribe a high fluoride toothpaste, so a 5,000 parts per million Durafat. I would advise to use a fluoride mouthwash at different times to brushing, and I will recommend that I would recommend to the patient that I place a fluoride varnish every 3 months and review their oral health every 3 months as well. Anything that you can do that you should know inside out that should minimise the risk of caries and other pathology forming, to minimise the risk for the need for an extraction. In terms of what you know, sometimes it's inevitable that you're going to have to extract a tooth. You know, patients might not want hopeless teeth extracted, or issues can happen irrespective of the prevention that you put out. So it's important to know how to manage these patients accordingly. So it's done based on low and high risk. So if you have a low risk patient, typically you treat the patient as clinically needed. So you would do the extraction. You give the patient, reinforce all the risks and benefits to obtain informed consent, and you would review the patient again in 8 weeks in the practice and check that the socket has healed properly. If the socket hasn't healed properly, then you can refer to secondary care for subsequent management. In high risk, it differs slightly. So if you have a patient who, you know, an extraction is an option, you would always consider the alternatives to extracting that tooth. So these are things like root canal treatment or restorative if it's possible. Can you leave pathology-free retained roots in situ? Or can you perhaps do a coronectomy so that you don't really have to affect the bone? If push comes to shove and you need to do the extraction, then at this point you can consider a referral to secondary care. I don't think anyone would turn their nose up if you referred a patient that's at high risk of MRONJ. Or you can treat as clinically needed and you can do the extraction. You can make that judgment and do the extraction in practice with the understanding that it's a risk. And again, review the patient in 8 weeks. If there's no evidence of healing, then refer them to secondary care. So those are kind of your management strategies. There are a few grey areas in terms of management of MRONJ. So the first one is antibiotics. Do you need to prescribe them pre-extraction? And currently there's no evidence to suggest you need to, so don't consider that. And is it acceptable to for the patient to take a drug holiday? Well, at the end of the day, you're not their oncologist or you're not their doctor. So this isn't judgment that you make. It's based on their clinician. And currently I think the guidance is that you wouldn't consider a drug holiday. Especially if a patient is taking bisphosphonates and you know the half-life is so long. So if someone asks you that in an exam, would you consider a drug holiday? It's not our responsibility, it's up to the clinician, but current evidence suggests that it is to be avoided. So I actually forgot I put this in, but let's quickly touch upon it. We did just speak about it. So low risk, you don't need to refer, do the extraction yourself, review in 8 weeks, and only refer if there's no evidence of healing. High risk, I don't think anyone's really going to turn their nose up if you refer a patient at high risk of MRONJ. They're not going to do anything different in the hospital compared to what you're going to do. They would still do the extraction either way. Perhaps they can take it out more atraumatically and reduce the risk of MRONJ forming. But you also have to consider your patient as well. So if a patient is in excruciating pain and extraction's the only answer, then you are going to be able to get them out of pain a lot quicker than if you refer to hospital. You can get the extraction done faster. That being said, I would probably refer patients, or I would definitely refer any patient who is taking one of these medications for malignancy, because it's quite complex, and I think a hospital setting is best for them, particularly as it's a higher risk. And if they don't have healing, they're already in that hospital system for treatment afterwards. This is just a table by the American Association of oral maxillofacial surgery. I'm not going to run through it, but have a look at it yourself. It basically just describes the stage of MRONJ, so not all MRONJ will present the same, and the treatment that you do subsequently for that patient. And again, before we move on to our next section, I'll quickly mention osteoradionecrosis, which is something we spoke about earlier. And it can present similarly to MRONJ, but it has a different etiology. So osteoradionecrosis of the jaw is typically or presents as exposed, non-healing, devitalized bone that's been persistent for a period of around 6 to 3 months in a patient that has a history of radiotherapy to the head and neck. In terms of risk factors for a patient, you have the proximity of the neoplasm to the bone. So if it's really within that bone, you're more likely to get ORN. Very similarly to MRONJ, you have more risk if it's mandible over maxilla, posterior over anterior, and then the same things, immunosuppression, poor oral hygiene, and ill-fitting dentures. Clinically, it will present slightly differently. In the early stages, it might be asymptomatic, but as you get on to the later stages, you can have pain in the area, quite non-specific, halitosis, paresthesia, so you can have a change in sensation. For example, if it's in the mandible and it affects the mental nerve, you can have a change in sensation to the lip, chin, and 1 to 5 teeth. And you can also have fistulae formation in the mouth as well. There are some management, but you only really need to be aware of these. But if you did have a patient you thought they might have osteoradionecrosis of the jaw, then you would refer them on to the hospital. So I guess MRONJ and ORN are complications of extractions, but there are others that you need to be made aware of as well. So alveolar osteitis, I really struggled to say that when I was recording, is a fairly common complication, and you probably more commonly know it as dry socket. And essentially what it is it's when you do an extraction and the blood clot doesn't form properly in the area, and then you get inflammation and exposed bone. It's really important to note that alveolar osteitis, I really can't say that, is not an infection, it's an inflammation. And the key giveaway for this is that osteitis ends in itis, which is basically a suffix for inflammation. So inflammation, not infection. There are a lot of risk factors for getting dry socket, things that you really need to be made aware of. The kind of two biggest risk factors I would say are smoking. And essentially smoking, what it does is the action of the smoke causes like a turbulence in the mouth and causes the blood clot to fall out or not form. And smoking also causes localized vasoconstriction in the area and can impair healing. The oral contraceptive pill is also a really, really big risk factor. And it also applies to females versus males as well. And this is because in the oral contraceptive pill, you typically have estrogen. And what estrogen does is it inhibits osteoclast activity, and it also induces fibrin clot breakdown as well. So two real key ones to be made aware of. Other risk factors include your classic poor oral hygiene. Always chuck that in. Previous history of dry socket. Third molars. Mandible over maxilla. Traumatic extractions. All your basics. Excuse me. And immunosuppression as well. Clinically, a patient will come in. You'll see them 2 days later on your clinic list, and after you've done an extraction, and you'll go, damn, they've got dry socket. And what they'll do is they'll sit in your chair, probably have a hand on their face, and they'll say, oh, I've got a real deep-seated throbbing pain that started yesterday or started this morning. They might not know it, but in the socket, clinically, you'll see like a grey-yellow slurry with lots of food debris, and they might have smelly breath, and in more severe cases, trismus or lymphadenopathy as well. The management is fairly straightforward. You would suggest analgesia to manage the pain, so ibuprofen or paracetamol. You would then irrigate the socket with a saline and debride it, and you can use local anaesthetic or not, it's up to the patient. There's anecdotal evidence of chlorhexidine causing a reaction in management of dry socket, so as your gold standard answer, I would say saline, not chlorhexidine, because of this anecdotal evidence. Then you would dress with Alvegil, which essentially would aim to soothe the socket, and you would tell the patient afterwards, not immediately afterwards, but a couple of hours later, start your warm salt water rinses again. I put antibiotics in a question mark because basically it's kind of a grey area about when you should and shouldn't prescribe antibiotics. And the SDCEP have great guidelines on when you need to and don't need to prescribe antibiotics. So the key points they say is that first step should be local measures, so irrigation, debridement, things like that. And then antibiotics are only indicated, and this applies for all dental infections, not just dry socket. Antibiotics are only appropriate when there is a spread of infection. So a spread of infection would present as swelling that isn't draining. It would present as trismus, lymphadenopathy, or you can also have systemic infections, so a fever if a patient is over 38 degrees, or the patient could feel, have some malaise or feel unwell, but it's not related to any other condition. So those are your key things for every dental infection. That is when you would prescribe an antibiotic. Oral antral communication, or OAC, is another risk factor with extractions, but only kind of maxillary posterior extractions. And basically it's a communication between the maxillary sinus and the oral cavity when you take a tooth out. The risk factors typically are very, very straightforward. It's kind of common sense. So you might take a radiograph and you might see a close relationship of the roots and the sinus. But obviously beware that an X-ray is a 2D image of a 3D head. So it might just be superimposition and there might actually be no close relationship at all, but I would treat it as if there is. You can have bone loss, which can be due to periodontal disease or infection, where the bone between the roots and the sinus itself has been degraded. Conversely, you can have hypercementosis or ankylosis around the roots. So when you do an extraction, larger chunks of the bone may come away, or it may be more traumatic. And yeah, excessive force as well. When you're taking an extraction out, you're at risk of, the luxator going into the sinus, or, like I said before, removing a significant amount of bone. How it would present depends on kind of the stage. So what you would have at your extraction appointment is the patient might have, when you're looking at it in a mirror to check for it, you might actually see a hole to the sinus. You might see bubbling within the socket, or you might hear a whistling sound. What I get my patients to do is I just hold the mirror there and I say, please breathe through your nose, and I see if the mirror is steaming up or not. Post-op, a patient might come back and say, I'm regurgitating a lot of fluids into the nose, or they might come back with a sinusitis. The management is dependent on the size of the sinus. If it's small, so less than 2 millimeters, you would expect this to spontaneously heal over 2 weeks or so. So you would provide them with what's called an antral regime, which is just your post-op instructions. These are things like don't blow your nose, don't smoke, don't use straws, don't play wind instruments. You would suggest the steroid or nasal decongestant spray. You would provide them with analgesia, so ibuprofen or paracetamol, and then you can consider antibiotic coverage as well. You would bring the patient back in 2 weeks and review them. If it hasn't healed properly, you would refer. If it has, brilliant. In a larger OAC, I would refer straight away to OMFS for them to patch it up. What they would do essentially is they would do some kind of flap to seal it over. So you have like a buccal advancement flap, a platal rotational flap, things like that. If your oral surgery skills are good in general practice, then you can do these yourself. You do your antral regime and then you would review the patient again in 2 weeks' time. Another complication of extractions is something called a fractured maxillary tuberosity. And the maxillary tuberosity essentially is a little fragment of bone that you can see on the x-ray and in the image. A little fragment of bone that is associated with the end of the arch, on the end of the maxillary arch. And what a fracture of this basically means is you've literally fractured that segment of bone, and it's usually when you take out a maxillary 8 or a lone standing maxillary molar. Risk factors, very similar to OAC, typically hypercementosis or ankylosis, where you're more likely to be gripped onto that bone strongly, and excessive force. In terms of the presentation, what you would hear at the extraction is you might hear a loud crack. That is not typical of a normal extraction. You might feel mobility of a segment that doesn't feel like it's just the tooth. Or you might extract the tooth itself and you might actually see the maxillary bone. There's my dog. The way you would manage it, would be, again, dependent on the size and the severity. I've done it before. I've extracted a tooth and the tuberosity's been on there. What you do is you would check for sinus involvement. If there's no sinus, you would just give your post-op as normal. You may consider a PA just to kind of get a little bit more information on this. If you have a fracture but the tooth doesn't come out, so the segment is mobile. If you have a small fracture, what you can do if you're feeling confident, if you don't want to refer, is you can raise a flap. You can then surgically dissect the tooth and the segment and then suture it again for primary closure. If you have a larger fracture, I would definitely consider referring to OMFS. Or if you're feeling confident or if your skills are good, what you can do is you can splint the tooth and the segment to adjacent teeth, leave it for around 6 to 8 weeks so the fracture can heal, and then in 6 to 8 weeks time you would do a surgical extraction of the tooth itself. And it seems fitting to move on to third molars after talking about an FMT, which is another key segment of oral surgery. And third molars, instead of using SDSEP guidelines, it's quite important to understand that you actually use NICE guidelines for these. There's some quite specific guidelines on when to and when not to extract third molars, so be aware of that. And the indications that NICE give for extraction of third molars include the following. So pericoronitis, if you've had 2 mild bouts or 1 severe bout, which we'll discuss shortly. If you have a third molar with unrestorable pathology, so caries, perio, PA pathology, fractures, things like that. If you have a disease of the follicle, so a cyst or a tumour related to the follicle of that tooth, perhaps the tooth might be impeding surgery, so something like orthognathic surgery, you might get rid of the wisdom teeth. Or if you have osteomyelitis in relation to that tooth as well, you might choose to extract it. And it's kind of, when you talk about removing a wisdom tooth that has no pathology, you have to weigh up the risks and benefits. At the moment, there is no indication to extract a pathology-free wisdom tooth. The evidence suggests that wisdom teeth erupting don't move teeth, don't cause anterior crowding, things like that, that a lot of patients think is a thing. If you have a wisdom tooth that you're concerned about, that maybe is a plaque trap, you wouldn't extract it, but you would monitor the 7 and 8 for caries. As soon as something happens, as soon as something forms, then you can whip that wisdom tooth out. You've got to consider the risk of taking a wisdom tooth out versus the benefit of what can happen. So for example, for any lower wisdom tooth, it might have a close relationship with the ID nerve. If it does and you extract it, you put the patient at risk of temporary or permanent change or loss in sensation of the lip, chin and teeth on that side, all of the things that the ID nerve innervates. So we just mentioned pericoronitis, and it's something that you're going to commonly see in practice, so you need to know how to manage it, when to refer it, blah, 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 blah. And essentially pericoronitis is inflammation of the operculum, so the little bit of gum that overhangs the distal portion of a lower wisdom tooth. Clinically, it can present in a mild or a severe manner, and it's important to understand both because this will determine your management. Mild, a patient will come in with pain, they might come in with a bit of smelly breath or halitosis, and they might have a little bit of pus discharge from the socket, from the gingival margins itself. In a more severe case, you'll have evidence of a spread of infection. So this will be things like, if it spread to the floor of the mouth, you could have a trismus, you could have a swelling in the area that isn't draining, and you can have associated lymphadenopathy and also systemic signs of infection as well. And your management, again, will depend on, is it mild or is it severe? So if it's mild, then If it's the first bout, then you don't have any indication to extract it and you just use local measures. So these are things like analgesia. You would irrigate with saline or chlorhexidine with or without local anaesthetic, depending on what the patient wants. Conversely to dry socket, you can use chlorhexidine in the management of pericoronitis. And then you would safety net. And safety netting would just be, you'd explain to a patient what the red flag signs are that the infection might be becoming severe. So swelling, trismus, lymphadenopathy, and things like that. In a severe case, then you now have your justification according to NICE guidelines that you can manage the tooth. So this can be via a coronectomy or via an extraction. If you choose to do an extraction, you might then consider extracting the opposing 8 as well, purely because that 8 is likely to be non-functional and it is now likely to over-erupt and become an issue with regards to cheek biting and trauma and things like that. You can consider removing the operculum. I've put a question mark there. It's not something I've ever thought about. And from what I understand is that if you were to just kind of cut the operculum off, then the likelihood is that it's going to grow back again and will still cause the issues. So if a patient doesn't want an extraction, then it could be an interim measure, but not a long-term solution. And finally, I've put antibiotics with a question mark. Are these or aren't these justified? Well, you should already be thinking about when they are or aren't. And for me, in my management of pericoronitis, even if a patient is coming back from an extraction, if they've got an evidence of a severe infection or a spread of infection, then I'm going to prescribe antibiotics, purely based on the fact that they've already got evidence of spread of infection. I don't want things to get worse and become a medical emergency. In terms of the antibiotics that you consider, your first line antibiotics would be amoxicillin typically. You'll prescribe 500 milligrams to take 3 times a day for 5 days. In a patient that doesn't get on well with amoxicillin or penicillins, your second line would be either metronidazole, which you would take 400 milligrams 3 times a day for 3 to 7 days, depending on what you decide, or clarithromycin, which you take 250 milligrams twice a day for 5 days as well. If we choose to extract a third molar, then we need to understand that there may be a close relationship between that third molar and the ID canal. So if you ever consider extracting a mandibular molar, it is essential that before you do it, you get a PA, or if you can't get a PA, you get a sectional OPG to visualize where those root apices are in regard to that tooth itself. In terms of kind of a guideline that you can use for describing this, the best one that I've found to use is the Root and Shahab, and it basically describes 5 scenarios that put the patient at a high risk of ID nerve complications. So you can see them on the picture on the left. And for any patient that has one of these signs, even though it's a 2D image and it might be nowhere near, I would always refer to secondary care for the patient to be managed there and have their tooth taken out by someone who's had extensive training in third molars in a high risk. We also have the discussion on, just throwing this in, if a CBCT is indicated. And again, it's one of these risk-benefit things. You need to understand that having a CBCT is a lot more of a dose of radiation than an OPG. And we need to think, well, does it provide us with a lot more information to justify that risk? And current evidence, there's a lot of evidence out there that suggests that whilst the CBCT will give a clinician perhaps more confidence when doing the extraction, it doesn't actually reduce the risk of ID complications. So personally, I wouldn't prescribe. As a GDP, I wouldn't suggest having a CBCT. But if I was in a secondary setting, then dependent on the OPG, it might be something that is considered. And if you do have a close relationship of these third molars to the ID nerve, or you have a difficult extraction, impaction, partial eruption, then an alternative to a full extraction is a coronectomy. And you can see it says here is if you have a high risk of ID nerve complications, or a patient that's at a high risk of MRONJ. You wouldn't do a coronectomy if you have any kind of pathology in the tooth where you may have infection of those nerves. You wouldn't do it in a patient who is immunocompromised, and you wouldn't do it if you saw mobility of the roots themselves. And then there's a little bit of information on the technique of the basics of how a coronectomy is done. I've also included a slide here on the principles of flap design when you may consider raising a flap, and the things that you should be doing. So have a good read through this. And I've also included just a quick slide on the types of impaction or a classification that you can use. If you're looking at an X-ray and you see there's an impaction of the third molar, the best ways that you can describe it as well. So that's basically it in terms of the bulk of the things that you need to know and the main things you need to know for oral surgery. There are some other considerations that they might throw in there as well, with the first being infective endocarditis. This is something that as dental practitioners we need to be aware of because it is a risk in dentistry, and we need to basically understand the risk factors and the management. So risk factors, the things you're looking out for in a medical history of a patient, is if someone has an acquired heart valve disease with stenosis or regurgitation. Perhaps they have a prosthetic valve replacement or some structural congenital heart disease as well. Management is, well, we need to know, do we or don't we use antibiotics, and what's the current guidance? And the current guidance is also produced by NICE, so make sure that you check this out. And the current guidance at the moment, although it is subject to review, is that antibiotics are not routinely recommended in a patient if you're having a dental procedure. The way you should manage a patient is you should explain to them the risks and the benefits to obtain informed consent, and then you need to explain to them why antibiotic prophylaxis isn't used anymore, with special mention to things like how the risk hasn't changed much, or antibiotic resistance and things like that. You should also give the patient information on the symptoms of infective endocarditis in relation to dental treatment. So things like fever, sweats, breathlessness, weight loss, and malaise. So if they have any of these, then they need to seek their GP for investigation. And finally, something that we need to be made aware of as clinicians is Ludwig's angina, which essentially is a spread of infection and cellulitis from the localized area to the sublingual and submandibular tissues. And it is considered a medical emergency, so it's something we need to be hot on. Red flag signs that we need to be made aware of: if you're looking intraorally with a swelling and a patient has a raised tongue or a swelling of the floor of the mouth, if they have a deviated uvula, which is that little dangly thing at the back of your throat, if they have dysphagia, so they can't talk or dysstridor, or they can't talk or speak properly or breathe properly, then these are all things that you need to think, shit, the patient could be in a medical emergency. And you would manage it like a medical emergency. So you would do A, B, C, D, E. You would check the patency of the airway, check the patient's breathing. They are your first two key management strategies. And then you would treat it like a medical emergency. You would call 999. You would then try and maintain the airway. So this could be with a oropharyngeal tube or a jaw thrust, something like that. And if it is escalating, then you can consider trying to surgically drain the spread of infection itself. So yeah, be aware of that. And that's it. Basically the end of the oral surgery lecturing or PowerPoint. Hope you found it useful. I have made an unseen case example that we'll go through now, just as preparation. So I've made this unseen case based on, experience, things I've seen. I've taken some x-rays off the internet and things like that. It's one that I used when I was preparing for my finals with my colleagues. And it's an example of the things that I'm going to have available for you guys at the end that I've made from my DFT year. And personally, I think that it's important to do it in the style that your exam will be, or in a similar format to your exam. There's no point you doing it with notes, and because that's not a way you learn. I think that even if this is early in your revision and you haven't done many unseen cases like this, the way that you will get the most out of it is by making those mistakes, highlighting where you need to learn and reflect, and then moving on from there. So I've just outlined a few rules here of how I think it should go. So it will be closed book, so you don't want any guidelines or notes near you. The only thing that you'll have in front of you is one sheet of A4 paper to take notes down. Set a timer for 10 minutes, because in the following slides that's basically going to be your case. And I think what you should do is you should flick between the slides and make all the notes that you feel are appropriate in that 10 minutes on that sheet of paper. Once the 10-minute timer's up, then you will move on to the questions, which will follow that. And there will be a series of slides that I'll leave on for about 10 to 15 seconds that you can pause it on. And then what I think is good for you to do is answer the question as if you've been asked it in a Viva. Then at the end, you'll see me come back on the screen with the questions, and I can give you the answer that I would give. And you can compare it to what answer you had, and basically, go from there, essentially. I would say, don't be upset if you can't answer a question properly because you're not at that point of your revision. Just answer it as best you can, and then use it to learn from. Write down the things that you think you need to improve up upon, or that you need to get a better understanding of. I was there when you were there, so I know exactly how the process goes. I was shit to start with, and by the end I got highest in adult restorative in the uni. So it's definitely a learning curve. And if you want to message me your answers on Instagram via video message or something like that, then I'm more than happy to give you guys feedback as well. So without further ado, let's put the cases on the screen. So I hope you guys found that a useful exercise, and we'll quickly go through the answers now and kind of see how we compare. So the first question is, give a brief description of the case or the history, and this literally is what it says on the tin, and you need to be able to do this seamlessly. You need to be able to reel off the key points, do it nice and quickly, about 30 to 45 seconds, and not waste any time. So the kind of way I would answer it is I would say we have a 75-year-old female that attended for a routine checkup. She complained that a tooth at the top felt weird in the upper left quadrant, and it started 3 weeks ago. There was no history of pain, and there was a foul taste in the area. Medical history relevant: she has type 1 diabetes and takes insulin. She suffers from hypertension and takes Ramipril, and she previously had a stroke and takes warfarin. She has no known drug allergies. Socially, she's a non-smoker and drinks 4 units of alcohol a week. She's a regular attender and brushes her teeth twice a day with fluoride toothpaste. She uses a manual toothbrush and no incidental cleaning. In terms of the examination, there were no abnormalities extraorally. Intraorally, there was a draining sinus on the buccal mucosa adjacent to the upper left 6. BPEs from the bottom were 121, on the top were 111. We were provided with a periapical of the upper left 6 and an intraoral photo as well. So I think that was bang on 45-ish. I was trying to look at the timer and my screen as well, because I just did it off the cusp. And I think the more you do it, the easier it will become. And it's just a quick way to pick up marks. So question 2 is, what further information would you like from the case and why? And this is typically things that may have been left out of the history that you need to understand to just basically get more information. So the type of things that I would say is, well, first I would address the history of presenting complaint, and I would say, well, has anything been missed out? And we don't really have much information on any associated symptoms. So is there any trismus, any evidence of spread of infection systemically, any history of swelling? These are all things that may lead me towards using antibiotics or not, so they're quite relevant. Perhaps you could ask if there's been a change in time over 3 weeks, so when did the foul taste happen? Then you would move on to the medical history, and you would want to gauge a little bit more information on the medical and social history. So the patient suffers from diabetes. We know that diabetes is a risk factor for periodontal disease and also causes immunosuppression, so delayed healing. So we want to ask, how well controlled is their diabetes? Do they have their diabetes checked routinely at the GP? Similarly, we picking up immediately on the fact that the patient is taking warfarin, and that should be red flags as soon as you see that word. And we need a little bit more information on the warfarin itself, especially if we have a tooth with a draining sinus. We might be considering an extraction. Excuse me. So we would ask the patient, well, do they have their yellow book with them? How often is their INR monitored? When was it last monitored? Is it typically stable? Things like that. In relation to that as well, the patient's told us that they've had a stroke. And a stroke can cause cognitive changes as well as physiological changes. So we need to be thinking, well, does the patient still have capacity to consent following their stroke? Does the patient have difficulty brushing their teeth now they've had a stroke? Do we need to put prevention strategies in place like Durafat, modified toothbrushes, things like this? I would say whenever you're considering an extraction, you would always ask, well, does the patient have a history of corticosteroids or bisphosphonates? I think that's an essential thing to ask. And we don't have any information on the patient's occupation, even though they're 75. We need to know, well, are they leading a stressful lifestyle? Are they still working? Who do they live with? Things like that, just purely based on, attending appointments, even though we know they're regular attender. Stress can affect periodontal disease and all the things like that. Just the general things that we need a little bit more information on. So question 3 is give a radiographic report. And again, this should be something that should just roll off of the tongue. Shouldn't take up too much time, but you should cover the key points. So the way that I would answer it is I would say we have a periapical of the upper left 6. The grade is diagnostically acceptable. You have the teeth you're looking at from the crown to the apex with a sufficient amount of bone apical as well. The teeth present, you have the upper left 5, 6 and 7. There appears to be some horizontal bone loss to the coronal third of the roots. In terms of radiolucencies, we've got a distal radiolucency on the upper left 6. There's also an apical radiolucency on the upper left 6, and we don't have any radiopacities. You can also comment on other things like why you're taking the PA, so to look for caries, bone levels, blah, 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 blah. You can also comment on things like, we can see the roots of the upper left 6 are close to the maxillary sinus, which might put them at risk of... So question number 3 is give a radiographic report, and this needs to be quick, it needs to roll off the tongue, not take up too much time, but you hit the key points as well. So the kind of things that, the way I would answer it is I would say we have a PA of the upper left quadrant. It's diagnostically acceptable. We've got all the teeth we're needing from the crown to the apex, and we've got a sufficient amount of bone apically as well. You would then discuss the bone level. So I would say there is some horizontal bone loss to the coronal third of the root. The teeth present are the upper left 5, upper left 6 and upper left 7. You can see radiolucencies. There's a distal radiolucency on the upper left 6 into the outer 2/3 of dentine. There's also a large, well-defined radiolucency in the apex of the upper left 6 roots as well. The upper left 6 and upper left 7, the apices of the roots appear close to the maxillary sinus, so we could be considering, if we're considering extracting, the patient could be at risk of OAC. And there are no radiopacities at all in the teeth. So you basically have addressed everything. You've addressed what it is, you can add why, you can have it's diagnostically acceptable, bone levels, teeth present, radiolucencies, radiopacities, and any other comments that you feel are relevant, like the sinus that I mentioned. So question 4, you find a supragingival buccal fracture on the upper left 6. What are your diagnoses for this case? The diagnoses I've given are generalized plaque-induced gingivitis. and I've given an upper left 6 with a supragingival fracture, pulpal necrosis, and a chronic apical abscess, or it could be a radicular cyst, according to the AAE guidelines. And this is a question where you don't want to stumble and miss things out. When it says diagnoses of the case, you need to remember we're thinking more than just the tooth itself. So we've got information on BPEs, which are 1s and 2s, so we know there's gingivitis. In terms of the diagnosis of the tooth itself, it's a shame this video is not out after the endodontic video, because I give a really in-depth explanation on how you obtain a diagnosis based on that. But in a nutshell, basically I've split it up into 3 parts. So we've got our tooth diagnosis, kind of the things you can see, so upper left 6 supragingival fracture. Then I've given a pulpal diagnosis, and we know based off of the sensibility testing and the state at which the tooth is, it's likely to have pulpal necrosis. And then based on the symptoms from our special investigations that you should have written down, we can ascertain that it's likely a chronic apical abscess as well. So question 5, sorry. What are the treatment options for the upper left 6? And I've got 3 treatment options for this tooth. So my first one, and the first one that you should have for any treatment options, is no treatment with the risk of spread of infection and the risk of pain, and in this instance the risk of further fracture. We need to understand that patients have autonomy. At the end of the day, it's their mouth and they have the right to an unwise decision. So even if clinically we don't think this is the right thing to do, we have to give them that option every single time anyway. My second option would be root canal treatment with a direct or indirect restoration. And then you would say I would also give the risks and benefits as well. I think that root canal treatment is feasible. It looks like we've got good periodontal support, and looks like we should be able to get good patency in the canals. So because I think it's realistic, that's an option that I would give to the patient. The third option I would give is extraction, with, again, the risks and the benefits. And then I would say space management as well, because you don't just want to leave the patient with a gap. You want to give them the options of how they can fill that gap if that's something that they wish. So I would say extraction and space management, with considerations for a denture, a cantilever or Maryland bridge, or an implant which can be seeked privately. So then next you might be asked, well, what are the risks of an extraction of the upper left 6 if that's what the patient wants? And you may have already highlighted them in question 5, in which case, fantastic, you'll get the marks and you'll move on a lot faster. But if you haven't, you need to give the general and the site-specific risks. So the kind of general things that you'll be thinking about are, well, the patient will have some pain and tenderness afterwards. The area might swell up slightly. There might be some post-op bleeding. It might be more difficult to stop them bleeding, particularly in this case because the patient's taking warfarin. So you might have to consider putting some sutures in. With any extraction, you have to give the risk of a dry socket. In this case, the patient's might be immunocompromised because of their diabetes. So we need to consider that a little bit more. Any extraction comes with the risk that the roots might fracture, and you might have retained roots. And I would explain in this instance, we do one of 3 things. So we would try and remove the roots ourselves. We would leave them if appropriate, and they would either dissolve into the bone or exfoliate themselves, or we would refer to the hospital to remove them. If it's a difficult extraction, which upper 6s typically can be, you might need to do a surgical extraction. And what this involves is you would cut the gums and you would raise a flap. You may require some bone removal to get the tooth out, and then you would have sutures placed afterwards as well. Damage to adjacent teeth is also something that can happen. Crowns can be removed, mobile teeth can be extracted at the same time. And for a more site-specific risk, especially seeing as that we've seen that PA, is you have the risk of oral antral communication in the area as well. So question 7, I actually forgot this was on here. So having answered question 6, I've pretty much answered question 7, and that's something that you want to try and do. You want to try and preempt the things they're going to say. So basically the concerns that I have, it's related to the risk of this patient in this case. So the first one I spoke about was type 1 diabetes and healing. Is the socket going to heal properly? Are we going to be at risk of a dry socket? We've seen the PA, so we know the roots there's a lot of bone loss and the roots are close to the sinus possibly. Therefore, we're at a risk of oral-antral communication, and that needs to be checked for afterwards. And we know the patient takes warfarin, and we know that warfarin is an anticoagulant that puts the patient at a high risk of bleeding. So those are the concerns. They were answered in the previous question. If you can do that, that's brilliant. So how would I manage this patient as a bleeding risk? Well, we now need to refer back to our SDSEP guidelines. And we're going to make that very clear to the examiner. So we need to consider a few things. We need to consider, well, what is the risk of bleeding in that extraction? Is it low or high risk? And then how do we manage that appropriately? So I would say something like, according to the SDSEP guidelines, we have a non-mobile upper 6 with quite a significant amount of bone. So I would consider this to be a complex extraction, and therefore the patient is at a higher risk of bleeding afterwards. Because the patient is a higher risk of bleeding afterwards, this is how I'd manage it. The first thing I would do is I would ask for the patient's yellow book and I would check their INR. If their INR has been done within ideally 24 hours or within 72 hours and it is less than 4, then I would continue with the extraction. If the INR hasn't been done within this time, then I would ask the patient to have a blood test and I would book the extraction for within 72 hours afterwards. And again, providing the INR is less than 4, I would proceed with the extraction. If the INR was greater than 4, I would delay the extraction and liaise with the GP. If I was to do the extraction, then there's a lot of bleeding management strategies I'd have in place. I would book the patient in for an early morning appointment or an appointment early in the week, so that if there's a complication afterwards, it can be managed appropriately. This doesn't apply to this because it's a single tooth, but if it was multiple, I would consider limiting the area or staging the extractions in multiple appointments. Once the extraction is done, I would pack with Surgicel and I would suture to encourage hemostasis. Tranexamic acid washes can be considered according to SDCEP, but I understand that it's not in the dental prescribing formulary, therefore I would have to liaise with the haematologist or the GP. I would give thorough post-op instructions on what to expect afterwards, how to manage it post-extraction, and I would also safety net, so I would say that blood in the saliva and toothpaste for a few days is normal. But if the socket was to ooze or drip or bleed blood, then I would give the patient a gauze. I would say bite down on this with pressure for 20 minutes. If it doesn't stop bleeding, then I would advise them to visit A&E or visit an emergency dentist or come and visit us again. I would finally avoid the use of NSAIDs or aspirin because these are antiplatelet medication, can have an antiplatelet effect and increase the risk of bleeding. And if I felt that it would be appropriate, I could also consider referral to secondary care. Question 9, they return 2 days later in pain, foul smell and a grey slurry in the socket. No other symptoms. What is the likely diagnosis? So we're thinking alveolar osteitis or / dry socket, either is appropriate. And in terms of management, these are basically the things that we spoke about earlier. I would say, I'd advise the patient to use suitable analgesia, so ibuprofen and or paracetamol. Things that I can do locally in the surgery, I can irrigate with saline and debride. I can use local anaesthetic or not use it, depending on the patient preference. I wouldn't use chlorhexidine because I understand there's anecdotal evidence that when chlorhexidine is used in dry socket management, you can have a reaction, and that's why I'd use saline. Once we've debrided it, we can pack the socket with Alvegil to soothe the socket itself. And then I would advise the patient to rinse with warm salt water around 3 to 4 hours post-treatment to keep the area clean and encourage the area to heal sufficiently. I would also go on to say that no other symptoms were reported clinically or by the patient. So if they were to ask, which actually I think is question 11, if antibiotics, which is question 11, if antibiotics are considered, then you would go back to your SDSEP antimicrobial guidelines, and I would say, well, according to SDSEP antimicrobial guidelines, there is no evidence of a spread of infection, so there's no swelling, no lymphadenopathy, no systemic symptoms, so fever or malaise, and no evidence of trismus. So in this instance, antibiotics are not indicated. and breathe. That's it. That's done. So that's basically your whistle-stop tour of oral surgery and a quick example case, which I hope you found useful. Please let me know in the comments or message me on Instagram if you did or didn't find that useful, because I'm going to include a case on every single video topic that I produce. So yeah, that's it. I don't really want to waffle on too much longer. Basically just want to again say thank you for watching, and thank you for the support. I enjoy making these videos, and as long as they're helping you guys, then I'm going to continue to do so. A little plug to follow me on my social media channels again, subscribe to the YouTube, hit the like button and all of that good stuff. And yeah, Endodontics will be the next video out because of the delay. So yeah, look forward to speaking to you guys in that one.